if you're on hospice program. The second question about hospitals, a little bit more complicated. So we hope that the patient, while choosing to be on hospice program, don't want to go to the hospital any longer. For many reasons, because hospital is not a comfort care, it's not about comfort, it's really aggressive treatment or curative treatment, aggressive sometimes life support.
Okay.
So, and we kind of assuming that if this person decided to be on comfort care, he or she doesn't plan to go to the hospital. Does it happen that people go to the hospital? Yes, it does. And sometimes we even approve it.
Okay.
And I will give you a couple examples from real world.
Thank you.
Yes, sure. So I had a patient who was with us on hospice care with a dementia. He fell down in the facility. He had a bleeding laceration on his head. Yes. So we were fine. We called ambulance. They took him to suburban hospital, to emergency room. The doctor there put stitches on the laceration, put like dressing or something. We didn't do MRI and didn't do CAT scan of the head because it already wasn't so much important to see what's going on there, since patient has an end-stage dementia and hospice patient. So we took him back to the facility by ambulance. So for all these things, ambulances, 2 ambulances, stitches, emergency room services, hospice paid, hospice, our organization paid out of pocket.
Wow.
Medicare didn't do it because Medicare assumed that if you're comfort care, we don't pay for aggressive treatment, which is emergency room visit.
Right.
Another example, and this is fine, we did it. Another example will be that somebody short of breath, calling us, we come in, the nurse coming during the night, the nurse administer morphine, sublingual morphine to make people feel better and breathe better, but family still insisting to understand what is going on, why my mom is not breathing good.
Right.
So they call in hospital, 911, they go there. Most likely, we will suggest them to stop hospice program. Because in terms of shortness of breath, let's say, in this case, our goal is to make this person feel comfortable and to make family feel comfortable about this, to explaining them that this is probably normal thing for congestive heart failure, let's say, disease, and that we are here to make someone comfortable. But if family would like to do CAT scan of the lungs, CAT scan of the chest, see what's going on, put someone, I don't know, on latex drips in the hospital, it's already not hospice care. It's against philosophy of hospice. The family has to sign just one paper. Nobody punished them for this. Everybody understands this. It's kind of life. They sign in one paper, and hospice stops the same moment.
Oh, so you're saying that if the patient can determine, like, no, I would like to receive curative treatment and discontinue hospice?
Yes. At the same time, we decided with them next day, let's say, but this date when he came to the hospital, and Medicare very generously, I think, reaches back to the aggressive treatment coverage.
Okay.
And when someone is ready to leave hospital back to community and wants to be on hospice again, we will take him or her on the program. But I have to warn, if it starts to be like back and forth, I go for treatment to the hospital, but I'm at home and I need some help, I want hospice, that's when we trying to investigate with the family or patient, what is your philosophy, what you really want.
Yeah.
There is nothing wrong to die in the hospital or to be intubated, it's okay.
Right.
But it's just a bit different path to go, and you have to make decisions. It's okay, it happens once, twice, whatever, but
okay, I understand.
yeah, so it's kind of like 2 different philosophies, and again, I personally and everyone in our organization, I'm sure, respect any any of the decisions,
Mm-hmm.
but there's decision to make.
Well, it's nice to know that it's that easy to determine, you know, a different path.
Yeah.
And that you guys are so flexible. And you've said so much, and so that brings me to, I have so many questions.
Sure.
So you talked about social workers, doctors, and nurses. What does the hospice care team look like?
Oh, this is a great question. My favorite one, because I love to talk about my coworkers. They are excellent. So each patient after admission, and admission is usually done by one-time nurse, admission nurse. They just do admission.
Okay.
And because it's a huge work, it's many hours work to do initial assessment and initial medications review and all these things. After the patient admitted, he or she is assigned to the clinical team.
Okay.
And it will be registered nurse, chaplain, social worker, and CNA, and volunteers. This is a huge team to take care of the patient. Patient and family. Patient and family absolutely must meet their nurse.
Okay.
So they cannot say, I don't want nurse to visit my house.
So
Nurse has to come and see the patient and assess the patient and see what is going on. All other disciplines, social worker, chaplaincy, CNAs like aides, are optional.
Oh, so all of those disciplines are optional?
Yeah, so people can, we have people who tell, and I'm not religious, I don't want chaplain at home. Although I think it's a big mistake because chaplaincy is not necessarily about religion, is just spiritual support, life review, just talk about life, which passed and what was good about this or bad. Same with the social workers who can help the family to deal with the small children in the house, how they understand death and disease process. They can help with the nursing home placement. They can help with the community resources to find the care. So I believe, honestly, when I'm doing information session, I always tell to my patient family, yes, it's your choice, but I recommend to have every member of the team to visit you.
It's a lot of support.
It's a lot of support, and from another side, nurse can come, let's say, Monday. On Wednesday, social worker came and see some signs of distress, and she will call the nurse.
Okay.
And alert her that, or him, that's what's going on. So they're all trained, they are people with a gold heart, they want to see to help. So I think they're all very valuable members, and people should take benefit from all their care.
So how often would these team members, like the nurse, the social worker, the chaplain, how often do they visit, and how long does the visit last?
Okay, great question. First of all, there is a lot of misperception that hospice is a custodial care and someone comes to the house and stay there for whatever, 4 hours, 8 hours, 10 hours. Unfortunately, it's not true. Okay. Hospice was created here by Medicare as a custodial, as a supplemental care.
So supplemental.
It's a supplemental care, and unfortunately, a lot of care still on the shoulders of the family, private pay, caregivers, aides, or nursing home staff, or assisted living facility staff, wherever where is the location of these patients.
Okay.
So how often the staff come in? Nurse, it's honestly very much depends on the particular patient. So per Medicare regulations, if I'm not mistaken, it should be every 7, why mistaken? Because it was changes during the pandemic. Okay. I think Medicare is back to what it was before. It's every 7 days as a minimum. Nurse has to come and visit the patient and assess the patient. They're doing it much, much, much more often.
Okay.
And in JSSA, we're trying to keep very low nurse to patient ratio to give our nurses more time to visit their patients frequently.
Oh, that's very important.
Yeah, it's very important. So we're trying to keep like 11, 12, 13 patients for the nurse versus many agencies can afford just like 17, 19, 20 patients to the nurse, which is a lot.
Right.
So how the nurse come in for routine visits again once, twice a week at the end of life, or if something going on, like let's say this patient in a pain. So she came on Monday, she assessed him, she called doctor, she changed the medications, and next day she can probably come again to be sure that this works now, this medication regime works.
Oh, evaluate
That it works.
Okay.
It probably will be night visit for the night shift to be sure that this medications and patient does and family does know how to give this kind of medications and have questions about it. Sometimes they come into pre-filled syringes, oral syringes for pain medication, for example. So at the end of life, in the last week of life, we should come every day.
So every day, daily visits.
We're doing daily visits. Sometimes it can be very complicated dressings and or drains, and nurse can come every other day or every day. I mean, it really depends on the patient's need. Chaplaincy and social workers also come in for the patients who like unfortunately we sometimes have young patients with the children, and probably these families need much more support from social workers and chaplaincy than other families. So it also depends on what is going on. Same with AIDS visit. This is the most requested people.
The AIDS visit?
AIDS, yes, because this is a personal care, and families asking how often your AIDS will come.
Right.
And I'm not allowed to say, you guys, how often, because like it can be, again, it's very much depends on the particular situation. But I will give you again one life example. We had patient who suffered from ALS, horrible disease. He was completely immobilized. So he was like 50s, and wife worked in DC. So she was out of the house for the whole day. And she was really thinking to place him in the nursing home because she couldn't take care of him already, like as much as he needed at this time. So we helped to arrange care at home, and he died at home finally. He never went to the nursing home. So we were trying to come every day.
Wow.
To wash him, to change him. After 8 come in to wash, change him, like few hours later, nurse just comes for half hour to see how he's doing. So we were trying to keep some frequent visits.
Right.
To be sure that the family is comfortable and he's comfortable. Versus can be other case when the patient can afford to hire 2 aides and pay like $30,000 out of pocket a month.
Costly. Yeah.
Yes, to have their private aides, and there is no need for them with our aides coming like 3 times a week to 1.5 hours to wash the patient, because they have their own hired people whom family and patient know for ages.
Okay.
So it depends, but usually I will give you just general idea. It can be few times a week, visit of 8 for personal care, and they usually come in for around hour and a half for bed bath, for shower, for probably changing the linens, feeding the patient. So it's additional, supplemental support.
It sounds like it's just highly specialized care, just centered on each individual. So
yeah,
that's wonderful.
Yes.
We do have a question, so
sure.
excited. So question is from Wanda. It says, is palliative care considered medical, and is it covered by insurance?
So we come into now to palliative care, which is not exactly hospice. If you if you ask me about hospice, and the question is about hospice, yes, hospice care covered by Medicare, 100%. And as I said before, unlimited time as long as the patient is eligible for hospice care. If we're talking about palliative care, and this is probably bringing us to the next question about palliative care, or you want to talk first about hospice, finish the talk about hospice?
Oh, I just answered, and then we can just go
Yeah,
on.
so if it was question about hospice, so again, what happens after 6 months? Medicare continues to cover hospice as long as we, as a hospice agency, can show to Medicare that this person is still eligible for hospice. Let's say he's less functional or she's less functional, eating less, sleeping more, weaker. If we can show this to Medicare, it will be not 6 months, it can be again 18 months or 24 months, it depends. Again, as long as eligible, as covered by Medicare.
But what about, you did mention the insurance, the private insurance,
Private
they have a lifetime of 6 months.
There are different private insurance, and some of them much more generous than Medicare.
Okay.
There are a few insurance who cover, let's say, even chemotherapy or intravenous fluids or something like pretty aggressive and hospice. So some private insurance, good private insurance, okay with this, which Medicare never will do. They never will cover, let's say, MRI, CAT scan, diagnostic test, chemotherapy, and hospice. Medicare never will do it, or Medicaid. Private insurance can, but there are other private insurance, it depends on the plan, that want patient to cover, let's say, 10% of the hospice coverage out of pocket. Or they are not happy with, they won't cover any aggressive treatment, nothing, just hospice. Or there's some of them who have just a time limit, like 6 months in a lifespan. And if this patient lives longer than 6 months, they won't cover hospice any longer. They just discharge the patient from hospice. And in this case, patient has to pay out of pocket for hospice, or we can take him or her on charity care if they have sick funds.
Oh, that's wonderful.
Yeah.
So that is an option.
It's the option for sick funds people to have, who doesn't have insurance,
Okay.
to go on charity care.
Okay. Do we have any other questions? Okay. And we have another question. Is it true that someone with a diagnosis of late-stage dementia can be on hospice longer than 6 months? Yeah.
Yes, it's true. It can be 18 months or more, as long as eligible.
Okay.
What is the difference between JSSA and Montgomery Hospice?
You need to read it out loud.
So what is the difference between JSSA and Montgomery Hospice? And they have a referral to Montgomery Hospice, so would like to explore JSSA. Exciting.
Oh, this is a good question. I actually worked for Montgomery Hospice 3 years. I was admission nurse there and liaison for hospitals as well. What I suggest, you just Google hospicecompare.gov. It's a government website. Medicare created it. You put in zip code where you live, and you will see agencies. Check Montgomery Hospice and check JSSA Hospice, and you will see parameters and how do they meet the parameters. It's based on former patients or families of the patients survey, and you can see who is the best in the area. And you know, guess why do I refer you to this website? Because we are the best. JSSA has a very high parameter. What is different? Montgomery Hospice does have Casey House, and this is inpatient hospice. As you know, this is a house, and this is a big advantage. And I would like to talk a little bit about inpatient hospice, if you...
The floor is yours.
Yes, thank you. So, what is it, inpatient hospice? Inpatient hospice is a hospital for hospice patients. So this is a place where hospice patient goes for acute conditions. So let's say I was doing again admissions. You come in for patient, young patient with cancer, very sad case, in pain, in horrible pain.
Mm-hmm.
So at home, you can suggest this medication, that medication, but unfortunately, it takes a while until this medication will act or will take pain under control, and patients continue to suffer at this time. So that's why all hospices have to have inpatient units or inpatient wherever beds to take symptoms under control. Montgomery Hospice does have Casey House. Very small percentage of people, probably less than 1% of all their patients go there. Because if hospice agency works very good and very on top of the problem, we are able to manage symptoms and take them under control at home. Up to the point that we can bring home, and I was doing this, PCA pumps and given morphine or fentanyl or any other pain medications through the drip at home. And person doesn't have to go to inpatient hospital.
Oh, so you can manage all of this at home.
We can manage at home, but we still have beds for inpatient care if there is acute problem with any hospice patients. And we have beds in the Montgomery Med-Staff Hospital in Albany.
Okay.
So if there is patient who has unbearable pain or shortness of breath, and we feel that management at home will take a while, we can take this person by ambulance to the hospital where we have bed, and our team will work together with the hospital team to put the symptom under control. Montgomery Hospice has their own house. They don't have to take this person to the hospital bed. But again, if it is, again, less than 1% of the patients will need this kind of care. Most of the time, it will be home visits that I explained before. And I can say that we have very good feedback from our patients. As I mentioned before, we have very low ratio between patients and nurses. So our nurses are doing pretty frequent visits.
Okay.
This is another difference. We are Jewish agency hospice, JSSA Hospice, but more than 50%, 50% of our patients not Jewish.
Oh.
And we have chaplains for any religion or any faith. And we have a couple rabbis for sure, but not only. So this is also some difference. And the difference is size also. You know, I'm down from Tenga, and I used to pass by the bank when I was going, Eagle Bank, I think, when I was going to dancing classes, and there was a good mortar there. We are big enough to know how, and we are small enough to know you. I mean, I was asking myself, can I steal this mortar? It's so good for JSSA, like from Eagle Bank. It's exactly for JSSA Hospice. We are second in size in the community after Montgomery Hospice. But we're still very personal because we are not very huge. And people feel like very personal touch. And for example, like nurse practitioner or doctor can text me and tell, Maria, I have a patient for you. And the same day we are doing admission. Like, you know, it's not like long, fast, like, and you're waiting until someone calls you back.
The personalized care.
Very personalized care.
Very important. Very important. Thank you. We have another question. Can I do dialysis and have home hospice care? That's a great question. Thank you.
Perfect question. It depends. And depends it on what is your primary hospice diagnosis. Let's assume someone coming for hospice because of the end-stage dementia and also has kidney failure and on dialysis. We take this person as a dementia person and consider that his or her terminal diagnosis, dementia. At this time, Medicare will continue to cover dialysis for this patient because kidney failure does not have anything to do with dementia.
Oh.
But I give you another example. Someone can have congestive heart failure and come to hospice because of the heart failure. And as we know, congestive heart failure can cause kidney failure.
Yeah.
And this person is on dialysis basically because of the congestive heart failure, let's be honest. In this case, Medicare won't pay for dialysis if patient is on hospice care.
So are you saying then the primary diagnosis cannot be related to why the patient is having the dialysis?
Primary diagnosis cannot be related to dialysis, or like patient has lung cancer and kidney failure at the same time. Dialysis still will be covered by Medicare because probably he will be with us for lung cancer and stage 1 cancer.
Thank you. That was a great question.
Thank
now,
you.
Raquel would like us to repeat who is a part of the clinical team for hospice.
Who's a part? Okay. So it's a registered nurse who is the case manager. They call the case manager for this patient. Social worker, chaplain, aide for personal care, and aides coming according to the schedule. So they're working from Monday to Friday, from 9, let's say, to 5. And let's say you want your mom to be washed Monday, Wednesday, Friday, from 9 to 10. And they have schedule, let's say, from 11 to 12. They have to put all their patients on the schedule. So aides will come. Sure, we will do our best to accommodate your request, but we cannot guarantee, like I cannot guarantee you now that it will be the time you want, but they come. So aides and volunteers. Before pandemic, volunteers were such important part. They were doing parties for people. They were sitting with the patients while the family goes to the supermarket. But we have volunteers, Reiki, massage, violin play. So all those things were great part of hospice care. And this actually Medicare requirement. 5% of the hours should be filled by volunteers.
So we've got nurses, doctors.
Doctors, yes, I'm sorry. I forgot one of the most important parts. We have 3 hospital doctors who are all hospice doctors who are all palliative care specialists. They are available day and night. And if nurse comes at night at 3 a.m. to visit the patient who is in pain, she can call our doctor on call, discuss what is going on, and our doctor will give the order, what medications to change or what to add or what to not remove. And our doctors sometimes doing visits at home if someone wants to see them and discuss. And this is, I think, also a big mark for us. I know that some hospices do visits, but I think we're doing it much more often per request.
Okay, so it sounds like that there's support 24 hours a day then?
Available, not in the home, but available.
But it's available if
Yes.
something happens.
Yes, absolutely, 24/7. You call at night and the nurse will do night visits, yeah.
That's wonderful. So nurse, doctor, volunteer, which is amazing, CNA, social worker, chaplain.
Yes.
So it's all part of the hospice care team, correct?
Yes, exactly.
Wonderful. And then, I did want to ask, you told me that in case of emergency, they take call, correct? Somebody's
Yes.
available.
We are available 24/7, and I think it's very big thing to have. And I remember I came to do admission for one lady, and she told me, old lady, I don't want hospice, no, I don't want anyone at my house. And the daughter told her, Mom, when you are short of breath, when you're calling me during the night and telling me that you are short of breath, but you don't want to go to the hospital, what should I do about this? And after that, she signed in, because really now they did know whom to call.
Good.
If something going on during the night, 24/7, we will do triage, so our nurse will talk over phone and tell what to do. And if it's necessary, we'll send the nurse as well at the same time. I was doing this night visits sometimes in the past, and you come in and a lot of things already resolved, because family was on the phone with triage nurse, and they already knew what to do. And very important part, which I fear that I will forget, death visits. So according to Montgomery County regulations, if somebody dies at home, you have to call 911 to police. Police come in, and this is very, very upsetting, very sad, very hectic visit. I was a couple times in this kind of situation.
I can imagine.
Yes, but if it is hospice patient, per Montgomery County regulations, you call hospice. You don't have to call police.
So you don't need to call the police.
You don't need to call the police. The hospice nurse will come, wash the body if you want, talk with you, hold your hand, call funeral home, will take care of all paperwork. Our doctor will sign death certificate, inform the doctor in the community, because you still will keep your attending doctor, plus to our doctor. So it's a big support in the kind of during the death visit and after as well, because we have bereavement program after the death of the person, which is 13 months. And we have all 3 support groups for people who lost their loved ones. We have support groups for people who lost their, I mean loved ones, but I mean spouses. There are different groups for those who lost children.
Wow.
Or just family members. Our social workers visit these families and do some calls, and very good trained volunteers do this as well. So bereavement program free, and it continues 13 months after the death.
So hospice is really not just for the patient, but it sounds like for the family, and it continues, the care continues long beyond the
Yes.
patient's death.
Yes.
Pretty
Yes.
amazing.
Yes.
Right? You mentioned all these services, and medication and all that, but are there any out-of-pocket expenses that the patient or the family incurs during hospice care?
I can say that the most painful, probably, expenses is day-by-day care, because as I said, hospice is a supplemental care.
Okay.
And if someone needs 24/7, like real custodial care, they have to either hire people at home, which is out-of-pocket expense, or family provides this care at home, or nursing homes, or assisted living. This is probably the most expensive part of the care at the end of life.
I can imagine.
Yes. Although hospice is free, but again, we are not there 24/7 to help. Out of pocket, others can be, for example, hospice does not cover physical therapy because physical therapy and home health covered by same part of Medicare, Part A.
Okay.
And this is really important to understand. Medicare Part A pays for hospital, which is aggressive treatment, for rehab or home health at home or physical therapy at home, which is recovery, okay? Medicare pays in hope that this person will recover after hospital.
Sure.
And will go home from rehab facility or home and still pay for physical therapy. Or Medicare Part A pays for hospice, which is another goal. It's a comfort care. It's no recovery. We hope for recovery, but we most likely don't expect recovery.
Right.
We want someone to be comfortable. And believe me, for dementia person, after hospitalization, physical therapy is not the best way to be comfortable, let's say. So hospice can pay for couple physical therapy sessions.
Wow.
Just to assess how things going. Is this person still can benefit from physical therapy or not? And if they can or not, hospice does not cover physical therapy in the future.
Okay.
In this case, some family who still has some hope for recovery can hire out of pocket. They do hire out of pocket physical therapists. This can be another expenses. I didn't see it so often, I'll be honest with you, because usually people come into hospice way too late that they really cannot participate in physical therapy.
Right.
But sometimes it does happen. Medications, yes, we review medications on hospice admission, and some medications don't make sense any longer. We continue to cover medications for blood pressure if someone has a high blood pressure. We continue heart medications, diuretics, many medications we continue to cover. But let's say it's vitamin, whatever, like 1,000 units, which this person used to take for years.
Yeah.
We don't think these vitamins make any difference in prognosis or in the life, in the comfort, so we don't cover it. And sometimes family would like to have this medication. They can buy them and pay out of pocket. We don't object. We just don't recommend them.
Okay.
Okay?
So it sounds like there's not a lot of out-of-pocket expenses.
No, it shouldn't be. If people like fully accept the philosophy, it shouldn't be many expenses. No.
Wonderful, wonderful. So Emily is asking us, do you use integrative care, including acupuncture, massage, and Reiki over at JSSA Hospice?
We do have, at least we did have volunteers before pandemic who was doing this. I don't think we have massagers in there or Reiki specialists in the staff of JSSA Hospice, but yes, we did use volunteers who were willing to do this for our patients. I, for example, have some degree in Reiki. So I remember I came for one admission and patient was in huge pain, and family told me do something because morphine was on the way, and I was doing Reiki for this patient. So, and I really hope it helped.
That's pretty incredible.
Yes.
So then we want to know too, we talked about a little bit about palliative. What's the main difference between hospice and palliative care?
Okay, so what is this palliative care? And why it's so often confused with the hospice care? The difference lies in the fact that while everything within hospice is palliative, not everything palliative is hospice.
Okay.
So like person can have cancer or chronic heart disease, and suffer from pain or shortness of breath or something like this. She continues to do chemotherapy treatment and visits palliative care doctor for pain management, let's say. And this is just one of his or her doctors. He has cardiologist or she has cardiologist, oncologist, regular doctor, and palliative care doctor who helps to put symptoms under control.
Okay.
It doesn't mean that this patient has 6 months prognosis or dying or has terminal cancer even, like it's, he can recover from cancer and be cancer-free in a while and pain will go away and all those things. Hospice is when curative treatment is already stopped.
Okay. So then palliative is when I still want more curative treatment, but I have certain symptomology that I need to be alleviated.
Yes.
And hospice is just relieve my symptoms.
Just relieve my symptoms. I'm not interested any longer. Why do I have pain? I don't want CAT scan or MRI to find the cause. I want to be free of pain. That's it.
Great, thank you so much. And then we're running out of time, but I want to get to one more question. And it's from Carol, and she's asking, when is it appropriate to switch from traditional medical care to palliative care? And then a little history. It looks like the patient has a dementia diagnosis, but still relatively medically stable. We want to maintain health as long as possible, but do not want invasive, uncomfortable medical procedures.
Okay. So I talked a little bit about hospice eligibility criteria for dementia. So usually it's end-stage dementia already, when a person does not eat too much, losing weight, not verbal any longer, incontinent is for sure. So this is when they start to be eligible for hospice. But honestly, it's your decision to make. It's philosophy. Because the sad things, when I'm coming to the families and they telling me, oh, we decided mom doesn't go to the hospital, she's 2 years at home, no matter what, we don't send her anywhere. And they're still not on hospice, which is sad, because they already philosophically made this decision not to go to hospitals, not to pursue aggressive treatment.
Right.
And they didn't call us. For this question, we have transitions program. You can call us anytime, and we can do transitions program. It's free program. It's community program. You don't have to drop any acute treatments or any curative treatments, but our nurse will discuss with you when is a good time to go for comfort care, for hospice, and we'll continue to follow with you. It's a monthly basis visits, or you can call anytime. I want to talk with my nurse. This is what happens. What do you think?
Okay.
Okay.
So thank you.
They want number.
Oh,
It's important.
Why don't you give them the number?
I will be happy to. You always can. Thank you for this question. It's very important for me as a liaison. So it's the main number of JSSA Hospice, 301-816-2676. You can find it in a Google. It's main JSSA Hospice number, and you ask intake department, and they will talk with you, and they will send you information, and I'm sure they will be helpful.
Yes, they will. Well, I just want to thank everybody who joined us today. Hopefully, your knowledge about hospice and palliative care has been a little bit more enlightened, and thank you so much, Maria, for joining us. Oh, can we type the number in the chat real fast?
In the chat? Can you type the phone number in the chat? 301-816-2676. Okay, thank you so much.
Thank you again, everyone. Have a wonderful rest of your day.
Thank you for joining us. Bye-bye.